Today we are having the 25th module, as I mentioned, promised last time. The next two classes are going to be essentially to see some major important long cases, how to approach. Once we have done that, probably after Diwali, we'll have a couple of days dedicated for discussing various surgical instruments one ought to see or discussed with, and also few of the common X-rays, those which we are not discussed earlier. So those will be the final 2 or 3 classes. Then by probably early December, we'll be concluding our 30 modules. If you have any specific topics you are interested to discuss, please inform either me or to Rajaram, my secretary, so that we can include those topics for our discussion, the final 5 modules. So with that, let's go on. I hope you are all able to see my slides and able to have my voice clearly heard. Please keep yourself muted for benefit of everybody. So today is an important topic as far as a long case is concerned, because this actually set the tone for your clinical examination. Because most of you, not all of you, will be seeing the long case as your first case in surgery. It will be commonly thyroid, groin hernia, breast lump, or abdominal mass, peripheral vascular disease, or varicose vein. So these are all few of the cases. And if there are other unusual conditions, they might keep, but one of these 5 or 6 invariably given to the every other candidate. And a hernia, thyroid, and breast. If you have, you should not have any element of doubt how to examine. And also there are some common questions asked, and there you should not have any hesitation of answering. Because if you are not able to do that, examiner come to a conclusion, he doesn't know even ABC of hernia or basics in thyroid. So it's very difficult to give you a clear pass. So that's the thing. So this is like a bottom level. So beyond which you should not go down. So these are all like an index cases. So where you should not have any faltering. So let us concentrate, try to get the minimum requirement satisfied as far as the examination is concerned. We'll see 2 or 3 cases. Then we'll try to use a template in order to understand those, how to examine. I'll tell from the surgeon's perspective, what are the key aspects that will be discussed after your presentation of the long case. Okay, so with that, we'll go. Like short cases I discussed in the last 2 weeks, this time also in a long case, you have time on your side. Usually, on average, you'll have 20-30 minutes with you. So no hurry in your examination. Take your time to take a good history, develop a good rapport with the patient, examine systematically, not to miss anything. Don't go forward and backward. Go systematically, inspect. Then only you palpate. Then percuss and ask the detail. Like that, you go systematically. Once you've done everything, put them in writing. As you start writing, you'll feel there are some things you haven't seen or examined. You can always go back and examine, fill in those gaps, then continue to write, and legible writing. That is what I require, because sometimes examiner likes to see your writing also. That will give, because we as surgeons, we like to see how the CRRIs or our junior residents are filling the case sheet. Very important, is a blessing for all of you to have a good handwriting. Flowcharts, some pictures, relevant pictures will take you a long way in surgical examination. Then at the end, you write in the case sheet the diagnosis, differential diagnosis, proposed investigation, and a couple of lines about the treatment for the given patient. It is not necessary to write the treatment, but if you write well and good, and the examiner anyhow is going to ask those questions. And while you're waiting, don't waste your time thinking about what happened yesterday and what might happen tomorrow. Just relax, enjoy the day, rehearse your answer, go and face the examiners confidently with a good eye contact. So this is what is important. When you talk to the patient, you just introduce who you are, And very, very important thing, there are 3 mistakes normally done by people like you, I'll tell you. The first thing is you keep on asking the patient, not expecting him to listen to you. So you have to just sit quiet, let the patient takes his own time to give you the answer to your question, because it will take initially a couple of seconds for him to understand you. That is a problem. So you have to speak the language of the patient, very, very important. So whether if you are asking about the bowel habits or his urinary symptoms, you just see, rephrase the question in such a way patient is able to understand you well. Then he'll come out, let him talk. If you are not able to understand what he is trying to say, ask him to rephrase his answer. Like that you see, in other words, don't like a parrot. Do you have pain? Yes or no? Is it burning? Like that, don't give him what we call a closed-end questions. How long is your pain? Can you describe the pain, how it is? Like that, you try to make it as open question as possible, so patient can be as descriptive as possible. So that is actually much more accurate and much more helpful trying to reach a diagnosis. Because otherwise, you go with a preconceived idea. Somebody might have said, oh, this is a case of gastric outlet obstruction due to CS stomach. Then keep asking him some close-end questions and preconceived thoughts. You end up digging your own grave. It should not happen. You make sure you go open-minded, open to criticism, open to all the problems. Then it will be easy and enjoyable. Now, you never falter in that technique. Second thing is systematically you examine. Go bedside manner. If the patient has to have all the 9 quadrant plus the 10th quadrant, for example, in the hernia or mass to be examined, make sure you see around. Is there any patient side screens are there? Pull the screen. Maintain some privacy. Very, very important. Or at least you cover the patient's genitals until the time when you are about to examine that part. So don't keep it exposed all the time. Examining of the breast, very, very important is to make sure you have some saffron. Somebody, if it is a male patient, yourself, your doctor, then if it is a female, then you have another nurse or somebody nearby to get the comfort of the patient on your side. Very, very important is keep the patient comfortable, and also you be compassionate. If the patient says, I'm feeling thirsty, go and fetch a glass of water. Something like that. Very simple but effective thing, because the examiner may not be standing there observing each and every step, but he'll be sitting in a table far away. From there, he is able to observe what you're trying to see. It takes only a minute for us to make a judgment. Are you a good, compassionate, confident doctor who knows what he's doing? It doesn't take too long for us. So be aware of all these things, be systematic, be comprehensive, and also, as I said, legible answers. Okay. Coming to the presentation, right? You have taken the exam and you're sitting right with an examination. The next 5 minutes is the crisis or the very important time for it is the time of this year. All you've done, practiced for the last 12 months is going to fetch you the harvest. Only how you are going to express or execute in the next 5 minutes in front of the examiner. So let your answers be very clear, crisp, very important. The way you contact, eye contact, and confidently. Don't show your overconfidence or ignorance. Be quiet. Always listen to the examiner when he is trying to address. For example, if he is interrupting you in between your conversation, try to listen to him. Turn your face like that. If the one examiner is calling you, you just look at him and listen to him. Then the other examiner, like that, you have eye contact with whoever is. Don't neglect the eye contact. Very, very important. Second, you nod your head as if you are able to understand. If you are not able to understand, sir, like that, you try to repeat what he say rather than telling, can you repeat the question again? That is very, very insulting him. So you rephrase in this. So does it mean, sir, you want me to tell, like that you tell, no, I didn't mean that, like that he'll say. In other words, you have to give an impression. It is only you not able to understand, he is not able to give you the right way like that. You don't put the blame on the examiner. Whatever happens, it is your fault. Okay. Never have an argument. No, sir, in our hospital, my professor only taught me this way of examining. Like that, don't argue with the examiner. Okay. There are 2 or more than 3 ways to skin a cat. So when you are examining the thyroid, you may be examining one way. The examiner may say slightly different way. Both are perfectly acceptable as long as you are all reaching a final conclusion. Okay, so there is nothing like there is one way. The book, Dawes book, Bailey book, there are different books will describe a different way of examination, but comfortable with one way, simple way, and least discomfort to the patient. This is what you should always do. Final thing is, give a clear-cut diagnosis. Don't just struggle there, because in long case, you are expected to give one definite diagnosis. Soon after the diagnosis, what is the examiner going to ask you? Why you do say so? So you have to substantiate your answer. So this man, elderly, smoker, pain in the leg, typical claudication with absent pulses. I think it is a case of like that. You can go TAO, whatever you say. So you need to substantiate with the appropriate history and also examination finding. That is the very important thing you have to do. The next important thing is a differential diagnosis. Very, very important. Okay. The differential diagnosis will at least should have 3 differential diagnoses you should have. Then any investigation needed, the examiner will ask you. Then you go for a systematic examination, like simple to more complex investigation you have to tell. Then treatment options also you have to tell. What is commonly practiced treatment, universe setup. You don't see what's done in UK or US. What is done in our region and what could be done for the patient in front of you or lying in front of you. That is much more reliable answer the examiner will be seeking. Okay. And then he will ask some theoretical question. Okay, you said something about the hernia. Tell me, what do you mean by irreducible hernia, strangulated hernia? Like that, he'll ask some simpler question, then slowly go into more and more advanced questions, depending upon how good you are. Okay, so there is no limit. There is nothing like a syllabus, but still the examiner will know this is the bare minimum. That is a maximum. If you reach the postgraduate level questions, that means you are already on the verge of getting the topmost mark. So good luck, all of you. Let's go on to see the cases. I'm going to show you 2 cases. Probably each one might take about 20 to 30 minutes discussion including. So probably by 12:15 or so, we'll be finishing today. Okay. Here is your first case. This gentleman, just watch him carefully from head to foot, concentrating on his neck. Of course, this I already mentioned is a thyroid case. So this is a 50-year-old manual laborer which came with a swelling in the region of thyroid for the last 3 months. So he came to us. Okay, you can see how he is looking. Let's go on with the next thing. This is what he said. So you have to get a good history, past history, personal, and also family history. And if it is a lady, of course, menstrual history. Coming to the present history, this gentleman, a 50-year-old manual laborer, came with a history of swelling of thyroid for last 3 months, gradually increasing size. And he didn't notice the swelling. His sister only noticed that there is something wrong in his neck. So he went in front of the mirror 3 months ago. He saw a small swelling. Now it appears to be slightly bigger. There is no sudden change. It is painless. And he has no history of dyspnea, dysphagia, dysphonia, or dizziness. Or you can simply say there is no history suggestive of any pressure symptoms, namely. Like that you can tell whatever pressure symptoms you like to, because we know thyroid, if it is large, malignant, it can cause compression of the trachea, esophagus, recurrent laryngeal nerve, carotid vessels. Accordingly, it can cause dyspnea, dysphagia, dysphonia, and dizziness. So we have asked all those things. Very important symptom. Next, This particular patient you saw now, this one, has a classically, he said, he is intolerant to the warmth. He is sweating. You can see his moisture in his palm. And also he is having a significant loss of weight. He said he lost nearly 7 kilos in the last 3 months. But he says his appetite is really more than good. He likes to eat very frequently, and he is really puzzled why he is losing weight. Okay, there are only 2 conditions to my knowledge where there is excess appetite, voracious appetite, even loss of weight. One, of course, diabetes mellitus, uncontrolled. Second, of course, is this one, thyroid. Okay, all other conditions, usually you have anorexia and weight loss, like tuberculosis, underlying malignancy, things like that. Next, another important symptom this particular patient is having is insomnia and a palpitation. The palpitation is the main reason why he was worried, because once you start hearing your own beats of the heart, that's a worrying symptom actually. Patient feels the heartbeat at night. So these are all the symptoms and no comorbidity. But in undergraduates, you tell no history suggestive diabetes, hypertension, ischemic heart disease, any previous thyroid surgery, because thyroid, especially the goiters, can recur after surgery. So you have to make a diagnosis if it is a previous thyroid surgery, it's a recurrent goiter or recurrent hyperthyroidism or recurrent nodule thyroid. Like that, you have to make the word recurrence should come in front of your diagnosis. The personal history, especially if it is a malignancy, familial, any family history, radiation exposure may be relevant. And as I said before, menstrual history. Paradoxically, a patient with hyperthyroidism will have amenorrhea. Hypothyroidism, myxedema patient will have menorrhagia. So that is another interesting observation. Coming to the examination, general and specific. General is, of course, the very important 3 things as far as apart from patient is not anemic, not jaundiced. Okay, you say all these things, but in addition, cyanosis, clubbing, all those things you say. But coming to the very important thing is patient has exophthalmos. You can see his eyes, especially the lower part of the sclera, the lower limbus of the cornea is nicely seen. Because he is looking slightly up, his upper limbus is not seen. But all of us, both the limbus of cornea is hidden by the eyelids. But here it is a prominent eye or a terrific look, we say, terrifying eyes, we say, or staring look. Exophthalmos is present, and you just ask a patient to spread and put a small paper sheet on the hand, and you can see the fine tremor. Fine tremor is very, very classical in a case of thyroid and also alcoholic withdrawal. These are the 2 things I would say, the fine tremor. And there are other reasons for tremor like intention tremor, tremor at rest, Parkinsonism, cerebellar disease, drug-induced, all sorts of things. You have to know the various types of tremor, but the common one cause for the fine tremor, of course, is a thyroid. And then some non-pitting pedal edema, that is a pre-tibial myxedema, is present in 10% of the people. It's not a common sign, I would say. Coming to the examination of the neck, inspect in front, palpate from front and also from back. That is what is important. Patient sitting with the hands by the side, you just stand in front, ask the patient, give a glass of water. That is a very nice courtesy of trying to see when the patient is swallowing, the swelling moves with the deglutition. That's very, very important. The sign of thyroid or a sign of a swelling which is attached to the pretracheal fascia or a Berry's ligament. Why thyroid moves with the deglutition? Very fundamental question, they say. Because of it is invested by the pretracheal fascia and it is stuck to the pretracheal fascia by a Berry's ligament. It is nothing but the condensed pretracheal fascia. And what other things will move with the deglutition? They'll ask you pretracheal, prelaryngeal lymph node, thyroglossal cyst. All these things you have to tell. In addition, you have to describe this patient is having enlarged swelling in the region of thyroid occupying both the lobes and isthmus. The lower border is clearly seen. There is no undue dilated veins. There is no scars. The trachea appears midline. So like that, you do the inspection. Then palpation, you say the palpation, it is not warm, it is not tender. Skin over the swelling is felt normal. The swelling feels very soft, uniform. There is no palpable nodule. It is diffuse, soft goiter. And you can feel if it is present, you tell it there is a thrill in the upper pole of the thyroid, suggestive of the high vascular gland. And the trachea, you examine from the front. The trachea is in the midline. Then examine the lymph nodes either from the back or front, and there is no obvious lymph nodes palpable. Carotid pulses are felt equally on both sides. There is no Horner syndrome, and on percussion on the sternum, especially manubrium sternum, it is remains resonant, so there is no suggestion clinically of retrosternal extension. On auscultation, there is a bruit present over the thyroid, implying there is a highly vascular gland. Then examination of the cardiovascular system, pulse rate is 1 or 2, regular, there is no pulse deficit. Respiratory system, respiratory rate is about 22, it is abdominothoracic. Abdomen, there is no organomegaly. CNS, but for the tremor, there is no deep reflexes, superficial reflexes, sensation, gait, everything is normal. Obstructive signs, ask the patient to just hyperabduct. There is no engorged veins, there is no dyspnea. Pemberton sign absent, and there is no hoarseness of voice. So this comprehensively gives an examiner that you have done a decent examination. As I said, there is more than one way of skinning the cat. You have your own way, but this is a very simple, universally accepted order, I would say. Try to follow this. The especially very important thing out of this is about the goiter. You have to describe the consistency, because that is going to tell us here. Lower border, very, very important for the examiner. Trachea and lymph nodes. So these are the 4 important things which differentiate from one candidate to the other candidate. Be careful when you have this examination. Don't go by the person before you said, oh, this is the case of Graves' disease, go. Then you go and you examine this patient as if you are examining without knowing any diagnosis. Completely. Okay, don't corroborate your diagnosis with the finding. You see, tell the findings as they are. Don't try to, okay, fool the examiner. Exophthalmos, if it is present, it may be tricky for you, because as an undergraduate, we don't normally expect you to tell or expect to know all the different signs, but at least you should be able to recognize the exophthalmos, which is a very, very important sign of the Graves' disease, rather than the primary hyperthyroidism, whereas secondary hyperthyroidism, like multinodular goiter turning into toxicity later, normally they need not have exophthalmos. So exophthalmos is a very, very important thing. And if it is present, it will be invariably kept in the examination. Like this lady, as you can see, the upper limbus of the cornea is seen. So if you watch carefully, it's a small. So you can see, I'll just wait for the examiner. You observe what are the findings. I'm trying to see the convergence. So in other words, this particular patient is having few of the signs, not all the signs. I've just enumerated here. You can always come back to this slide in the YouTube and go and reverse, because sometimes in a prize exam, they also ask all of the things. Very important thing is this patient, if you see, because there is a prominent eye, it is not a proptosis. Proptosis is usually, it is a forward bulging of the eyeballs because of the retroorbital swelling problem. Here, it is because of the mucopolysaccharide deposits and also some lid retraction. You have the apparent, the prominence of the eyes. So no forehead wrinkling. This is what first I wanted to demonstrate here, the Geoffroy sign. If you see here carefully, sorry. When you ask a patient to look up, you see here. So there is no forehead wrinkling at all because the eye so she not even wrinkle to in order to elevate her eye. So there is no wrinkling of forehead. Yes, that is present. Stelwalk sign, no blinking of upper eyelid because of proptosis. There is no wrinkling, but this is not clearly apparent here. But she had some lip retraction, especially the lower eyelid retracted, dull wrinkle sign. Convergence is a little less, so she's not able to come right to the medial end of the eye end to look at your nose, tip of the nose, at your finger touching her tip of the nose. Mobius sign was positive, and Von Graf sign. So these are all the various signs you may have to look for. Okay. So the classical finding in a Graves' disease, a soft diffuse goiter like this patient, terrifying look because of the staring eyes, tremor, yes, tachycardia, 4 out of the 6 he already had, and a blood test done showed a TSH low, T4 very high. So confirmed pre-tibial myxedema. If it is present, well and good, but this patient didn't have. That doesn't matter. So 5 out of 6 T's are present. So it is a classical case of a Graves' disease. This is another case, just to tell you, this patient had a goiter, diffuse multinodular goiter with some features of no pressure symptoms, no toxic symptom, just opposite. He had actually hypothyroidism. He was telling, I always feel so sleepy, doctor, feels constipated. I feel as if I don't have energy because he was a pusari. So he was not able to do the puja, thing like that. So you may have a classical case of hyper, some cases of hypothyroidism also knocking the door of your clinics. These are a few recollecting points. How to examine the patient from behind. Okay, because examination of the neck is better because you are able to concentrate with your finger and mesmerized by your eye sign. So inspect from front, palpate from behind. It's like hernia. You inspect while the patient is standing and then palpate while the patient is lying, like that. Okay. Tracheal position also very, very important, how you look with your index finger and then you see how it goes, whether it's shifted to one side. Usually when you have a large nodule on one side, the trachea tend to go on the opposite side. It can be demonstrated both clinically, sometimes better by radiologically. So always you have to do an X-ray of the thoracic inlet. Then auscultation, very, very important, especially when you are suspecting hyperthyroidism. You have to put the stethoscope over that superior and inferior thyroid artery territory where you will see a bruit, audible thrill. Okay. Then retrosternal goiter, you have to percuss over the mandible. No need to give a hand. Directly you can percuss because the bone is there. You directly percuss. Some people percuss over the other index finger also or middle finger. So Graves' disease, exophthalmos is present. Mainly tremor, CNS is affected. Whereas toxic multinodular goiter, exophthalmos is absent and it affects cardiovascular system. Elderly people with the atrial fibrillation, very classical thing. So you have to look for pulse deficit, irregular beat. They might ask you all sorts of questions as far as the thyroid Graves' disease is concerned. It'll all come to surgeon. Okay, what surgery you will do, doctor? Or is normally done for this case? You have to tell. Sir, nowadays it is either a subtotal or near total thyroidectomy. What is subtotal thyroidectomy? Removing the whole thyroid, leaving only 1/8 of the gland. There is a 4 grams of tissue or size of the patient thumb on either side. Why you leave that? So it will have some amount of thyroid function and also it helps to preserve the parathyroid and also recurrent laryngeal nerve to large extent. So the indication for thyroidectomy is to know various types of goiter like intractable toxic goiter, multinodular goiter for cosmetic reason or present symptoms, or malignant goiter. Consent is important. Explain the patient there is a 2% chance of hoarseness because of the temporary injury to the recurrent laryngeal nerve. Not always. Preoperative preparation. Usually for a toxic goiter, you bring the patient to euthyroid status. How do you bring the patient to euthyroid status? By keeping the patient on antithyroid drugs, including beta blocker. non-selective, cardioselective beta blocker, interval, propranolol, you give in such a way that the sleeping heart rate comes down to around 80 to 85. Usually it is 100, it will come down. Sleeping pulse rate chart used to be a regular thing for nurses those days. Now we don't give that important, but still it's nice to know. Okay, because morning time, because of the anxiety, the heart rate may be variable, but at night when the patient is sleeping, you measure the pulse rate, you monitor the case sheet, you see it serially over a few days, and if it is a clinical sign of euthyroid status is heart rate coming below 80, things like that. So that is a thing. So what are the things you give? You give beta blocker, anti-thyroid drugs. Usually in our country, it is a carbimazole. In US, propyl thiouracil. That is what we normally give. What is the important side effect? They'll ask you. Agranulocytosis. How do they present? Sore throats. So what do you tell the patient? As soon as they have fever, sore throat, or oral ulcer, they have to stop medicine, come and have a hemogram done to look for agranulocytosis. Okay. And once that done, any other drug can be given. It used to be a customary practice to give Lugol's iodine in the past for 2 weeks prior to surgery. Why do they give it? Because the swelling, there is a thyroid is normally very vascular and friable. To make it less vascular, less friable, and more easy to do a surgery, surgeon conventionally we give this Lugol's iodine. But nowadays we don't rely on that. It is not easily available. But you can always tell the purpose of Lugol's iodine is to make the thyroid less vascular, less friable. If you say that, that is fine. These are all the pre-operative preparation. Any investigation? Usually X-ray neck is enough to look at the tracheal position, X-ray chest. Of course, cardiac assessment, ECG is required, basic blood test. In addition, ultrasound is normally done. If you suspect retrosternal extension only, you have to do a CT scan. Okay. Then about the surgery position, patient in supine with a reverse Trendelenburg, head end raised. Why head end is raised? So venous congestion is prevented, less bleeding if the head end is raised. Like varicose vein, what we do, operation, Trendelenburg position, there is foot end is raised. Okay, so this is the same way, just opposite to the varicose vein surgery. Then incision, low skin collar incision. Okay, so that it is hidden by your dress if possible. Then main steps, skin, platysma, incised, then lift the skin flaps, then the investing layer, cervical fascia, pretracheal fascia is incised in the midline, strap muscles are retracted, thyroid lobes are exposed, the vessels, the middle thyroid vein is the first vessel ligated, very, very important. Middle thyroid vein is a one vein which goes from the thyroid lobe directly to the internal jugular vein. It can cause torrential bleeding if it is avulsed. So it has to be ligated, followed by superior thyroid pedicle, then inferior thyroid vessels. While you are ligating the superior thyroid pedicle, care about external laryngeal lobe. When you are ligating the inferior thyroid pedicle, care about not to damage recurrent laryngeal lobe. So these are the things. And when you do the thyroid, we try to identify, preserve all 4 parathyroid glands. Okay, parathyroid has to be seen and preserved. Recurrent laryngeal nerve has to be seen and preserved. Okay, these are all the common concepts nowadays we follow. Achieve hemostasis, leave a drain, do a closure, monitor the patient post-operatively, look for any complications. Okay, that's the main steps. Coming to the how long you continue the anti-thyroid drugs after surgery is another thing they'll ask you. Usually, the propyl thiouracil or a carbimazole, if the patient is on before surgery, you stop it immediately after surgery. There's no need to continue. Only beta blockers are continued for 3 to 5 days to maintain the heart rate because of the manipulation during surgery, patient may have excess thyroid hormone in the bloodstream that can lead into tachycardia, even thyroid crisis. So for that, patient needs a few days of continuation with beta blockers. That's the only thing we'll give. So this is what normal thyroid, and this is what after surgery, a small amount of thyroid, both parathyroid and recurrent laryngeal nerve. How do you identify recurrent laryngeal nerve? That's the next question they'll ask you. It is usually in the tracheo-esophageal group. On the right side, the vagus nerve gives rise to the recurrent laryngeal nerve, which goes around the right subclavian artery. On the left side, around the arch of aorta, ascend on the tracheo-esophageal group between the branches of inferior thyroid artery. So the notorious place where it can get injured is when you are trying to ligate the artery. So we have to be careful. That's what you are expected to tell. So tell me few complications of thyroidectomy. They ask you. Thyroid is very vascular gland. Okay. So if there is a bleeding, the bleeding contained within the pretracheal fascia, it can cause tracheal compression, laryngeal edema, respiratory distress. So hemorrhage is a fatal complication. One has to be. It is not the volume of the blood. It is the blood collected under pressure over the trachea causing a respiratory distress. That's going to kill the patient. So you have to watch for this. That's why we always keep a drain so that whatever is collected comes out in a bag, suction drainage. Next, of course, is a dreaded complication is, especially if the patient is a singer, you had it. Because if you injure either of these two nerves, recurrent laryngeal nerve or external laryngeal nerve, both can cause change in the voice. Hypoparathyroidism also is possible. So patient may have tetany, hypocalcemia. They'll ask you all the different signs, at least the Trousseau sign, Earp sign, thing like that. Okay. If you don't remove the enough amount of thyroid, if you leave large chunk, then patient will have a persistent hyperthyroidism. If you remove the whole thyroid, patient may go into hypothyroidism, which is easy to manage. After surgery for Graves' disease, if they ask you, you tell hypothyroidism is easy to manage because you can always give a small dose of thyroxine hormone, L-troxin. Whereas if the patient has the same disease like Graves' disease again, persistent, it is difficult to manage. Then patient has to be submitted for redo surgery or radioactive iodine. So that's why hypothyroidism is easy. So always people say, if at all you want to remove, you err on the excess side. You better remove total thyroid rather than trying to remove less amount of thyroid. Okay. Now all other things are less common. This is a lady, as you can see, had a surgery done. You can see a low skin collar incision. And this is another case. Sometimes you have a diffuse toxic goiter. Next case is a nodular, multinodular goiter. Third is a malignant goiter with the lymph nodes. These are the three classical cases kept for you. This is a second case wherein you have a large multinodular goiter. You can see a large swelling in the region of thyroid occupying both the lobes with a large nodule easily visible both in the isthmus and also the left side of the lobe. Moves with the deglutition, lower border is seen. There is no undue dilated veins. There is no scarring. Trachea is not easily seen. Then you palpate. It is firm, nodular, and non-tender. Mobility is preserved. Then you can feel the pulsation of the carotid behind. There is no lymph nodes. Trachea and palpation found to be in the midline. And percussion, there is no retrosternal extension. Like that, you can carry on. They'll ask you one or two specific questions related to the nodular goiter. What will you do? Investigation, ultrasound, FNAC. Then you proceed for whatever. So if you do an FNAC, they'll ask you, how will you do an FNAC? Then you have to be able to tell. I'll take a 10 ml syringe, sir. It's an outpatient procedure. There is no need to give a local anesthesia. I go into the swelling after explaining to the patient how to examine and aspirate, maintain the suction. I go several passes with the maintaining the suction. So the needle will suck the aspirate and that will be sprayed over a slide and it will be immediately fixed with isopropyl alcohol usually, and then sent for pap smear, and it's seen by an experienced cytologist who can tell exactly whether it is a carcinoma, what type. The only limitation is in a follicular tumor, you will not be able to differentiate a follicular carcinoma and follicular adenoma, because this differentiation depends upon the category of vascular or capsular invasion. So the vascular capsular invasion is only histological diagnosis, not a cytological diagnosis. So looking at the cells, that is a limitation of the FNAC. And the cells are classified according to Bethesda scoring 1 to 6. Next, they'll ask you theoretical question. Do you understand what is a cold nodule, hot nodule, warm nodule? So you should be able to, when you do an iodine scan, which is not commonly done unless this is a case of malignancy, sometimes you'll have a nodule which has no uptake of the radioactive substance. If you're giving technetium or iodine, usually if it is an active gland, it will take up. Whereas if, for example, if this nodule is having only fibrosis or a fluid or non-functioning tissue, then it will not take up the radioactive substance. So that area in a gamma camera will not take up any radioactive substance. It will appear empty. Whereas here there will be a lot of radioactivity, no activity, radioactivity. That is what is called cold nodule. The common 5 causes for cold nodule, in addition to carcinoma, it could be a degenerating colloid nodule. That is the commonest cause for cold nodule. Okay, colloid nodule is cold nodule. Remember now. Carcinoma, colloid nodule, cyst, all 3 C for cold nodule. Then lymphocytic thyroiditis, rarely follicular adenoma also. Okay. Then I told you about the Berry's ligament. That's why you have the movement of the trachea, the thyroid with the movement of the with the swallowing. But Berry's sign is another sign that also by this time you already know. In a patient with a cancer of the thyroid, the nodule will go and encase the carotid. So you will not be able to feel the carotid pulsation on the side where you suspect malignancy. If it is anaplastic cancer, the whole, both side carotid may be absent. You will not be able to feel it. Okay. So that finishes the thyroid. I think we have done reasonably okay. We'll quickly finish the groin hernia. Any questions anybody wants to ask? Let me stop sharing now. You can unmute and you can ask me some questions. I'll give you about 5 minutes. Jagan? Anything? Good morning. Anything you want to ask? It's okay.
Sir,
Yes, go on.
Sir, can berry sign be present in any other swelling other than carcinoma, sir?
You can see if there is any swelling over the carotid. Yes, of course, theoretically, but it is by tradition related to only thyroid malignancy. So let us be very clear, for undergraduates, there is limitation. There is always exception to the rule. So see, for example, but what berry sign implies is normally, if it is a benign enlargement of thyroid, the carotid is pushed posteriorly. It keep on pushed because it's like, but whereas if it is malignancy, it is infiltrated or encased. It goes all around. So that is what we are trying to impress. So even if you have a huge multinodular goiter so big, still it can have a carotid pulsation palpable, much posterior, but it still will be present. Whereas if it is a small but malignant goiter, it will try to infiltrate the carotid sheath and the carotid pulse will be either weak or absent. So it is a sign of infiltration. It is usually any malignant process for that matter, but usually thyroid. Bharat, yes?
Thank you, sir.
Anybody else want to ask any questions? Let us have one more question before I go. Arun, Karshini, you have any clarification in thyroid? Long case, or you are confident, because you should know by this time how to systematically examine and also what common investigations, and how to interpret FNAC, limitation of FNAC where it is not suitable like follicular neoplasm, and why. These are all typical questions. You should have a confident answer, reverse your answer. That's what I keep telling you. Okay. Right, let's share the screen one more time. I hope you're all able to see my complete slide. We are approaching another important topic. This is like a bread and butter stuff for all surgeons. I'm sure this topic has been addressed by umpteen number of times by several of your assistant, associate, and professors of your own college. But still, it is something which worthwhile revisiting, because hernia chapter is always exciting, both to operate and examine, because it always gives you that element of surprises for every case you see. When you have go and examine the patient with a groin swelling, you go with that. Okay, I'm going to ask this chart. For example, this particular patient who is presenting with obvious swelling in the right groin on standing, or able to observe there is an inguinal swelling going right up to the scrotum, and you ask a patient to cough, it is having a cough impulse. Immediately you know it is a type of a groin hernia, whether it is a femoral, direct inguinal, indirect inguinal, you have to examine, or it is something like a hydrocele of inguinal cord or spermatic cord, we need to see. But you need to go with this open mind, ask some questions. How long you had the swelling for, like that. So this patient was telling, sir, I've been having a problem of swelling in the right groin for the last 8 or 9 months, especially when I go in a bike, and at the end of the day, I feel there is some swelling appearing, and it is sometimes painful, but when I lie down, it goes out. In the morning, I hardly see any swelling, and I don't have any problem with urination. My stream is good. There is no nocturia. I don't have any history of constipation. I don't smoke. I have no chest symptoms. Like that, he may tell. And I don't have any history in the past of being treated for hypertension, diabetes, or ischemic heart disease. I had appendectomy done 10 years ago, open appendectomy. Personal history, I am just an IT personnel and working in a different city. I came here to get a consultation from you. This is normally the patients tell me. Then drugs, especially if they are on aspirin, clopidogrel, warfarin, very, very important 3 drugs. Because three drugs will determine when we are going to operate. Because there are a humpty number of drugs patient may be on, but these 2-3 drugs put a break on the day when we do operation. Because you have to wait for a few days for the bleeding time, clotting time to come back to normal. So surgeons are very fond of knowing whether the patient is on aspirin, clopidogrel, or warfarin. If they are present, please tell them separately. Examiner will appreciate you. Okay, this is what the patient, and that's patient are lying also. So inspect on standing. That is the first thing you always do is examination on standing. Very, very important for varicose vein, inguinal hernias. Another thing is examination on lying down. You start with the reduction, then you examine step by step. All this, inspect, palpate, then examine the scrotum separately, then examine the rest of the intestine. See, like for example, here the very short, ultra short video, just to show you, just see the video, then we'll come for the examination. Okay, this particular patient, as you can see, has a prominence in the groin region, both sides and standing. Left side more prominent than the right side, and it appears bilateral groin, there is inguinal hernia. There is a lot of hair, but there is no obvious scar. And there is an impulse on coughing present. On lying down, I just put a marking from the pubic tubercle to the anterior superior leg spine. That is a surface marking for the inguinal ligament. But in the exam, you can put always the imaginary line. You see whether the swelling in relation to the pubic tubercle is below and lateral, or above and medial. Whether it is here or here, that you will be able to do. Finger invagination test is demonstrated here, but usually not. I don't normally personally expect the candidate to say, because it is very painful for the patient. Okay, you just go and see, ask patient to cough and see if the swelling whether it comes and hits your tip of your finger or side of the finger. If it comes and hit you the front, direct, and the side is indirect hernia. Okay, then you go for a deep ring occlusion test, ask the patient to cough. When you do that, you will find out whether the patient is having a ring occlusion test, accordingly direct or indirect inguinal hernia. Once you have finished all this reducibility, relation to pubic tubercle, ring occlusion test, then you examine the scrotum because associated hydrocele. If not, what is the status of the test is very important, because sometimes after hernia surgery, because of the inguinal hernia repair, patient may go for a testicular atrophy. So it is very important to document the size of the testis on either side. That's why we always examine beforehand cord structures, any thickening or anything. Then examination of the abdomen, like enlarged bladder, sometimes present in a patient with a chronic retention of urine. Chest, because patients with the COPD, patients are known to have chronic cough. That may be the reason for direct inguinal hernia. Always tell the examiner, I'll do a rectal examination also, just to see that the patient has no obstructive cause in the rectum to explain his constipation, or I'll also look for a prostate enlargement, because a presence of prostate means patient has a high chance of retention of urine after a hernia surgery. So patient with a large prostate with prostatic symptom ideally would require urinary symptoms or the prostate surgery done before the hernia surgery. So this is the importance of rectal examination. So if you do all those things, then you tell the diagnosis in 3 stages. First, side. This particular patient, I showed you the video, bilateral. Then it is recurrent. No, it is not recurrent. So don't put that suffix beforehand. So it is not a recurrent. It is a primary bilateral hernia. Is it inguinal? Yes, it is inguinal. It is a bilateral direct inguinal hernia. Okay. If you want to add on more, if it is a direct, it itself says it is incomplete. If it is indirect, you have to tell it whether it is a bubonocyl, which is above the external ring, or it is coming down to the scrotum, that is complete hernia. Okay, if it has some difficulty of reduction, whether it's irreducibility or sliding inguinal hernia is another terminology sometimes you are expected to know. Femoral hernia in an examination is very rare. In a female elderly, it could be a case for 1 in 10 times, but never make this diagnosis as a first diagnosis. It is very uncommon in an undergraduate. So it is usually direct or indirect inguinal hernia, unilateral, bilateral, recurrent or primary. Okay, these are all the things. And have a clear understanding of this particular chart, because it's very simple but very, very important. What I'm trying to tell here is this one. That is, if a patient given to you, 80% of your cases for undergraduates, they have a reducible hernia. So they'll have a cough impulse present, and either swelling is reducible spontaneously or reduced by patient or reduced by you by using a maneuver that is called a taxis. TAXIS, that is patient's head, leg flexed, hip flexed, and also internally rotated to relax the muscles. Then you just squeeze the content slowly. And usually if it is a lot of momentum, it takes a little time to reduce. So that is called a taxis. So you have to see whether the swelling is reducible or not. Why? Irreducible hernia, obstructed hernia, strangulated hernia, or emergency operations. Reducible hernia, you can always do an elective surgery. What are the signs of irreducible hernia? Absent cough impulse and not able to reduce the contents completely. Is there any other cause for irreducibility? A partial irreducibility is a feature of sliding hiatus hernia. Sorry, sliding inguinal hernia. Okay. Next question, immediately they'll ask you, and I'm sure you are all expected to know while you're waiting to face the examiner, is anatomy of the inguinal canal. They'll immediately ask you, tell me, what are the anterior, posterior boundaries of inguinal canal? So you have to visualize the inguinal canal here. in front of the inguinal canal, the skin, 2 layers of subcutaneous tissue, external oblique aponeurosis. Okay, then you open the inguinal canal. What is posterior wall? The posterior wall is the conjoint tendon, the arching fiber, and then the transversalis fascia and peritoneum. Only three. What are the contents? Spermatic cord and a ilioinguinal nerve. And then they'll ask you, what is superficial ring? A deep ring. Superficial ring is a defect in the external oblique aponeurosis. Very, very important. Deep ring is a defect in the transversalis fascia. A constant anatomical landmark for deep ring is the inferior epigastric artery, because inferior epigastric artery is medial to the deep ring. Okay. So even if it is a large hernia, bilateral hernia with a buried penis, when they lie down, usually you'll be able to reduce like that. Okay. And you should know a very classical thing, never get confused. Midpoint of the inguinal ligament. You draw the line, imaginary line between the pubic tubercle to the anterior splenic spine. The way I did, midpoint of that is called the midpoint of the inguinal ligament. Just 1.5 centimeter above that is the location of the deep ring, wherein you place your hand, ask the patient to cough after the reducing the contents. If the hernia reappears, that means it is directly coming, because directly defect in the posterior wall, it is coming. Whereas if your hand is keeping it inside, there is a deep ring, by occluding the deep ring, the hernia is not coming out on coughing. That means it is the indirect hernia. So this is because you know the root of the indirect hernia. It comes out through the deep ring into the canal. Whereas here, it bypasses the deep ring and comes here. So that is a very simple diagrammatic representation and understanding, and a clear understanding. Malgain's bulge on lifting the head present in elderly people with a bilateral direct inguinal hernia. This is the indirect inguinal hernia on the right side. The finger imaging test is only described here, but discouraging students not to do it, in my opinion. In abroad, in the UK, we don't expect them to do it. But in our country, if it is possible, you do it. But I personally feel it is waste of your time. Because nowadays we know it is enough if you make a diagnosis of reducible hernia, irreducible hernia, inguinal hernia, femoral hernia. There is no need whether it is a direct hernia or indirect hernia. When that is possible, what do you think is a direct hernia can turn out to be an indirect hernia during surgery, because it is only an anatomical problem and there is no hard and fast rule. So that's why examiner will not penalize you if you make a diagnosis of direct hernia, indirect hernia mistake, or if you fail to do a finger anatomy. So this patient was examined already by few candidates. He was feeling uncomfortable when I was explaining to do. He didn't give me a consent to perform. So that's why I omitted. Then examiner will tell you, okay, fine, but tell me what will be the interpretation. Sir, when I do this, when hernia, if I ask a patient to cough, if it comes and touches the side of my finger, it is indirect. Tip of my finger, it is direct. Like that, if you are able to interpret by describing the examiner, that is well and good. Then examiner will ask you, okay, doctor, what will you do? The usual terminologies you do follow is herniotomy, herniorrhaphy, hernioplasty. But nowadays it's better to use Bessenis repair, Solde's repair, Lichtenstein's repair, because these are the three commonly done procedure open. Bessenis, high recurrence rate, that is the problem. At least 10% recurrence rate. But here what they do, open the inguinal canal, external oblique is incised, open, isolate the sac from the cord structures, transfix, excise the cord, the sac. That is called herniotomy. Then approximate the conjoint tendon to the inguinal ligament by using a non-absorbable proline suture interrupted like this. That is Bessenis repair. So approximation of the conjoint tendon to the inguinal ligament. Very simple. What Solde's repair? Here recurrence rate is 1%. See there 10%, here it is 1%. So very good operation. But here it is not one approximation is a 4-layered repair. Very, very important. We don't use a mesh. So what we do is we divide the transversalis fascia and do a what we call the plication. Okay, transversalis fascia is done in 2 layers. Then conjoint tendon is approximated to the inguinal ligament next layer. And the final layer is external oblique is closed. So these are all the 4-layered closure. If we say 4-layered closure with the prolate, no use of mesh, recurrence rate is 1%. What about Lichtenstein's mesh repair or tension-free mesh repair? Here, inguinal canal is opened, hernial sac is removed, then we put a proline mesh. Okay, the whole procedure can be done under regional anesthesia or even local anesthesia. What is the recurrence rate? 0.1%. So 10, 1, 0.1%. In other words, 1 in 1,000 patients only will have a recurrence rate. Very good. That's why invariably most of the patients nowadays in our hospital or country undergo Lichtenstein's mesh repair, otherwise called hernioplasty. And equal number of patients now, at least in the private setup, they go for a laparoscopic mesh repair. But this needs a general anesthesia. Make incision to 3 tiny ports in which you go on to place a mesh. There are 2 routes we do. They are called tap and tap. What is tap? Laparoscopic transabdominal. That is, you go into the peritoneal cavity, go into the groin region, make an incision in the peritoneum one more time, and then enter the pre-peritoneal space. So you enter the peritoneal cavity, then you go into the pre-peritoneal space by incising the peritoneum. Whereas here in the extraperitoneal TEP procedure, extraperitoneal or pre-peritoneal space is directly entered. We don't breach, we don't enter the peritoneal cavity at all. So this is usually a preferred approach nowadays. This is because the virgin area is unnecessarily, you are entering another territory, another country, something like that. So it is not preferred. The preferred approach nowadays is step procedure. But in both, we put a mesh. We put a green color. This is a mesh. So it is totally pain-free day case procedure. But it needs general anesthesia. I told you umpteen number of times. Femoral hernia, which is usually below and lateral, compared to above and medial is inguinal hernia, is rare for your exam. They'll ask you if it is kept the anatomy of the femoral canal, which is governed by 3 ligaments and 1 vein. Inguinal ligament, Cooper's ligament posteriorly, lacunar ligament medially, and a femoral vein laterally. Clockett's lymph node normally present inside the canal. And the patient, beware of an elderly lady presenting with a groin swelling. Invariably, it will be a femoral hernia causing a Richter's type of hernia. Richter's is a one knuckle of power like this one will get stuck. Okay. Occasionally, you can have a case of an incisional hernia or umbilical hernia also as a case if there is no inguinal hernia like this lady. So such patients, history is almost same as in inguinal hernia, but you have to inspect both patients standing and lying. That is the only difference. Invariably, most of them will be overweight. So we mention about the patient's, body mass index. And when you reduce here, you have to tell the examiner additional very important point, the defect size. After reduction, the defect in the umbilicus or defect, incisional hernia defect is about, it admit 3 fingers or defect is about 3 or 4 centimeter in diameter, sir. How will you accurately assess the defect? If they ask you, you can always tell, I'll do a CT scan, because CT scan will tell me whether there is any, in addition to which you are able to clinically see, there are subclinical defect can be seen. They are called Swiss cheese defect. See, if you cut a Swiss cheese, there are small, small holes, similarly, which are not apparent in the surface. As you cut, slice open, it will be all seen. Like that Swiss cheese defect also will be seen with the incisional hernia, which are very easily seen in a CT scan. It is like thyroid nodules may be felt, but some subclinical nodule, what you do? You do an ultrasound. Same way here, to know the defect, subclinical defect, you look for a CT scan. Okay. What treatment? In hernia groin, I told you various operations. Here, Mayo's repair, where they are double breasting the linea alba, or mass closure using a non-absorbent rolling suture. Third is a mesh repair. So either of these three, the mesh can be kept either on the surface of the linea alba only or deep to the muscle. Let me just see. Okay. I'll go. And just wait and see whether my slide is seen. I'm just going to share the screen. Let me just see. Are you able to see my slides? Huh? Are you able to see my slide? Which one you are? Question. Which one you are seeing my slide? No, just a minute. New share. Question time. That one I'll just see. Now? Are you able to see now? Question?
Sir?
Are you able to see now?
Yes, sir. I can see now.
Okay. Fine. Sorry about that, friends. I think I was disconnected.